surgical remove facet joint, it's okay, no problem. That's why. But some doctor trying to, the disc space is narrow, so I will insert the cage to encourage the disc space. No, it's I think the commercial industrial mind people, the patient have all the future already. In the case, just the full decompression or the total vasectomy is best. So sometimes the patient will have all the future, right? That's what we can do, full decompression. And sometimes after the total removal facet joint, sometimes you can see this vertebral artery sometimes. Right? But don't worry about that. I told you, yes, cervical muscle is very important. Press. And it's the bilateral foraminotomy. You can see bilateral foraminotomy, but there is no any damage of spinous process ligament complex. Bilateral foraminotomy, one side approach you can do bilateral decompression. Happy, okay. But no damage of spinous process. It's a video. This is ipsilateral. You can see root of the foramen, and then over the top, and you can see contralateral side foramen. You can do bilateral. Yeah, I know this is it's a very rare case of a bilateral foraminal stenosis, but in case of you can do with one skin port, ipsilateral and contralateral, bilateral foramen is possible. In the case of the acute disc, you can do endoscopic H-dep also, like this. H-dep, anterior approach. Advantage is that the endoscopic spine system will provide both visualization, will carry the safety. First time, for one level, H-dep endoscopy is 1 hour is enough. And the post-operative anterior soft tissue is really very less. Endoscope is like this. Calcify the disc, anterior approach, you can do. Planning like this, you can do endoscopy. It's my paper about the endoscopy plus H-dep and the corpse angle post-operative and the disc height and every clinical outcome was good. It's the case calcified disc. Plan is anterior approach, the midline corpectomy, only central region, midline corpectomy, and then serialized, very simple instrument. But yeah, it's serialized, and then you can do anterior calcified region, only central, midline corpectomy, can do endoscope. How was the operation? During the operation, no any bleeding will provide good visualization. And you can see this zero hypertension. I told you the only midline corpectomy and pre and post operative. And the approach is the same like the open surgery between the keratosis and the asparagus. And you can push anterior organ. It's a trachea, asparagus, and you can push anterior organ to opposite side. And you can use the needle and the serial dilate and endoscopic stem. And how is it compared to open surgery? Big skin scar and the muscle and with the endoscope with a 1.5 centimeter, you can do everything. Before the implantation, you can see dural pulsation. And some patients have like this flexor extension. The dynamic MRI shows true pathology, posterior anterior. In that case, you can do posterior decompression first and anterior approach H-dep. So post-operative first decompression, posterior decompression first, and anterior approach H-dep. You can do simultaneously. So this process. So endoscope, you can see discectomy using the calcium punch and the drill, and then you can remove the PLA like open surgery, and then you can insert the cage under the endoscope view. So the 80 male patients have two pathologies, posterior buccal ligament and anterior disc, epidiameter less than 5 millimeter preoperative. wide space of the spinal canal with what small space in the endoscopy approach post decompression first and anti-HDF. Advantage could be to know the less bleeding, so you can provide the good visualizations. First, before the insert the cage, first we can insert the cage wall first, and then you can set the cage, and then you can insert. And cage 3, 4, 2 pathology. First, posterior decompression and anti-approach. Posterior decompression first, anti-approach HDF. And it's everything. This is my first case of endoscopic spinal surgery in 2017 HDF. It's a heart rate, it's my heart rate because that is scary me because there is no any teacher, no any conference. Now I can do just endoscopy, operate HDF less than 1 hour. Okay, it's my published paper. The only 2 papers published is my paper and Spain Dr. Christian Morgenstern is the only 2 papers have published in the world about endoscopy HDF. Anyway, endoscopy spinal surgery everything, cervical, thoracic, lumbar. In conclusion, endoscopy will guarantee the best return their patient normal life and changing the indication and method of operation because you can avoid the fusion surgery. It's quite different between microscope and open surgery because endoscope there is no any damage of the posterior ligament complex. That's why in case of grade 1 lumbar small joint distances, we can try the decompression instead of fusion surgery. Okay, so my operation room is that operation are 100%